Oh, love, rub.
Maybe just to go on that one there. Wanted to tell you about the positions of the baby. Good. Um, if you take a look at this slide here, when we're talking about positions of the baby, um, what you're looking at here is the fetal part. Okay, see that? The dark area, that's the fetal part. So when the baby is in this cephalic or vertex position, the head down first, okay, the baby's heartbeat will always be found on the side of where the oxygen is. So in other words, it's going a little better. The baby's heartbeat is heard the loudest in the back, the baby's back, okay? So if the baby is in this vertex agitation here, like this one is, and that one is, okay? When you want to listen to the baby's heart, what you're going to do is try to figure out which side the baby's head is on. Okay?
Anterior.
So,
14.
okay, Leopold's maneuver. Now this is from the second page here from the second textbook, second edition, not the third. Okay. So what happens is when a woman goes into labor, you want to assess what side the back of the baby is located on. Okay. So the way that we go about doing that is by doing something called Leopold's maneuver. Okay. The first maneuver, and this is from the outside, the external part of the mom's belly, which we're feeling. So we start at the top of her uterus, and what we're doing is we're trying to figure out if the baby is vertex or breech. Okay. And how we do that is, if the baby is breech, then we're going to feel the baby's head at the fundus of mom's uterus, okay? The head is actually mobile, moves. So you're going to feel a round head on, when you're feeling mom's uterus, and it's going to be able to move back and forth, okay? If the baby is vertex, you're going to feel the baby's backside, okay? And that is not, you can't move it back and forth, it's not all by itself. So it would have a round shape, but it wouldn't be like mobile like the head is. So the first maneuver is trying to see, right here, see how, and it's not internally. Some people just do goes, oh, you put your hands all the way up in one's belly like that? I'm like, no. It's externally just with your hands. Sometimes I don't think you have to clarify, but that's something but then we thought of that. Okay. So you can see here, this person is, feeling, to see what they feel. The head would be moving back and forth, the tush doesn't. Okay. So that's how you sort of distinguish between that. Okay. And then here. The second maneuver is to locate which side the fetal back is located on, because that is where you get the fetal part, the best. So if you think about, so what you're doing is you start the fundus, feel what's up there first, and you put your hands down the side. The back is nice and smooth, and where the baby's feet and hands aren't as smooth. Okay, so what you're feeling is the smoothness of the back, and then you'll know which side the baby is lying on. Okay, and when you're feeling the front of the baby, you're feeling like the feet and hands. Okay, so then you know it's not. So you can see here. Why do I want to know where the back is? Because we want to know where to put the fetal monitor. That's the baby's heartbeat is heard much better in the back than the baby's back. That's the third maneuver, and on that we're just trying to see if the baby's head has descended into the pelvic cavity enough. And again, it will also determine which position the head is in. Again, the round part of the head is the occiput area, so then you would know that the baby is going to be located on the right side of the mom, because the occiput is facing the right side of the mom. We also know that it's right occiput, RO, okay? And the baby's head is facing more towards the front of the mother. See the back of the baby's head is more to the front. So we know that this baby is an LOA, right? You understand that? The back of your landmark is the occiput with the baby. So the left side of the mom's pelvis, right side of the
Right
mom's
occiput
pelvis.
anterior.
And the baby's head, back of the baby's head is facing the right side, so we have R, O, and we see the baby's head is more to the front. You see more, see how you see this part more, so you know that the occiput is more to the front.
So
That
it's
would
either
be
OP,
LOA.
OA, or
Okay.
NT.
ROA.
Okay.
ROA.
Transverse.
ROA.
Yeah.
Okay. Then the other thing is where we're going to listen to the baby's heart, right around this area here. So whatever side the baby's back of the head is the same side as where the heart will be located on the back. Okay. So with this baby in this position, vertex being ROA, the heartbeat, if you say this is the belly button of the mother, that's her abdomen, you divide it into really into 4 components. So above the belly button to the right is the right upper quadrant. Okay, the left upper quadrant is over this way above the belly button. Below the belly button, this is the right lower quadrant, and this is the left lower quadrant. When you're listening to the baby's heart, when the baby is vertex, you're going to hear the baby's heart, that's where the back is. And what location is that? ROA, right? Okay, so it's the right side, ROA. It's where you can hear the baby's heart rate the best. Okay. Yeah.
I'm like a little confused with transverse, because with transverse, like I would think that's transverse.
You would see, no, you would see the profile better. See how you see the back of the baby's head really well?
Oh,
You know what I'm saying? That's the back of the baby's head. Transverse, you see not as much of the back of the head, you see more profile on the baby. Okay? And then, let's see. And then again, we have the fourth maneuver, again, to test the baby's and heads engaged, you know, it's in the right place. So, that's the, how you figure out where the back is located on the baby. Okay, so again, now we're looking at this baby, and where we find the baby's heart. Again, you'll see with this baby, the baby is, the head of the baby, the occiput is facing mom's left side.
Occiput anterior.
The occiput is more to the front of the mother. Okay, so that's anterior. So we have LOA is baby's position, and the heart rate is located in the lower left quadrant. Okay, you see that? Everybody else see that? This is going to be a test question for you. I'm going to have a diagram, you have to know that. Okay. Yeah.
so if it was posterior.
So this is showing, let me just quickly show, they're saying this woman is in labor and where do they want to put the heart? If the baby is LSA, that means the baby's breech, because the sacrum is the part that you're locating. So any baby that is with the S in the middle, meaning the baby's going to be breech, you're going to find the fetal part in the upper quadrants. Okay? You'll find the fetal part in the upper quadrants. So if it says that the position of the baby is left sacral anterior, where are you going to find the fetal part? In the left upper quadrant. Okay? If the baby is right sacrum anterior, you'll find it in the right upper quadrant. That's breech baby. Okay? If the baby is vertex, it's in the lower quadrants. Okay? So the lower quadrants are babies that are coming to head out first. So all of this, when it says O, the landmark is O, it's the occiput and the baby is coming out head first. Everybody get that? Okay. So here is not the greatest picture, but let me show you the posterior.
That's
I scanned that picture onto
wow,
not
perfect.
perfectly done with the computer.
God, I got jacked.
So you see here, the LOA or ROA again, and again, sorry, you can see here a little bit, I made a line where you think the belly button is, okay, on the mother. And so you can see this baby, the back of the baby's head is on the right side of the mom's hip, and the fetal part is going to be located in the lower right quadrant. This baby is also, the part is located in the lower left quadrant, okay? Okay, this is the pig. See the difference in how the head is located? Okay, so if you take a look at these babies, posterior, okay, position here, the baby is here. Again, the landmark is the occiput of the baby's head. So the back of the baby's head, where is it located? Okay, so this one here is saying that the baby's head, the occiput is facing a little more. I would have to look better pictures of this so you can see it a little clearer. The baby's head is more, the occiput is more to the mother's left side. Okay, again, so we have LO because we know it's the left is the occiput, and then the baby's head is facing. The occiput is facing the mother's posterior side, okay? So posterior, you can really tell the difference in the pictures here, when the baby is, the back of the head is right by the mother's spine or whatever sacral area. So these kind of, a woman who has a baby's head like this, the posterior position here, has a really long, hard labor. That's when she has a lot of back pain, and the baby's head is facing that way, okay? And then, let me see if I can get this hand this onto this, so it's sort of jumps if I maybe go too fast. Okay, and here we have the baby that is breech, okay? And again, what we're looking for with this baby is breech baby. So where's the back of the baby's head? Facing the left. Where is its back? On the left. Okay. So whatever letter, if I said the baby, I'm going to say, let's say the baby's, RSA or LSA or whatever I say, right away you're going to know that the baby's heartbeat is on that side, the left side, okay, or the right side. So whatever letter it starts with, that's where you're going to get the baby's heart. Okay, because the sacrum's in the back and the occiput's the back of the baby's head. So, so you have this baby here. You have the occiput of the baby's facing mom's left side. Okay, or sacrum, sorry. Sacrum is facing the left side, and the baby's head is a little bit more to the front. Okay, interiorly. Okay, so you have LSA. Again, this baby's sacrum here is facing now the mom's right side. So it would be sacrum, the right sacrum, and the baby's back of the baby's head is a little bit more to the anterior. Okay. Yeah.
So
Huh.
you can use it if it's LOP or ROP.
No, yes, well, they, right, but they'll know what they're feeling, you know what I'm saying, so they know the baby, what position the baby's in, yeah.
That. Hello. Jack, stop it.
I'm so hot. Nice.
Is that the picture you took on my party? I mean, was that the same Jack you were at my party?
Okay.
You took a picture of me. You were like,
Yeah.
oh.
Also, why the same day as me?
Huh?
This is the baby having an internal fetal monitor. Sometimes you'll see for the most part that the baby will have a external monitoring device with a strap that's belt around
Oh yeah,
the
that's the
belly.
thing that screws on.
That means external. Sometimes it's hard to get fetal heart rates on people who are very obese or if the baby's in a strange position. So they will be able to use something called an internal electronic monitor. Okay. and they have a scalp electrode and they screw it into the baby's head. Okay, and there's in the lab I'll show you a real one that it looks like. So it's a sterile technique. The mom has to be dilated at least 2 centimeters. The water has to be broken so they can get into touch the baby's head. And they use this if they cannot get a monitoring device picking up the baby's heart rate on the belly of the mom. Okay. Let me get back to where it is.
Is there caffeine in this? I need freaking caffeine.
My slide, when I do these slides, I do like 100 slides, race of slides.
On some of
This
this.
is important slides. I'm trying to get the YouTube, just to put the YouTube's on there. But if you go on to the point, when it says students, you know what they have for the student? One of the things is they have videos, and they have a video with a cesarean section, and a video with a woman in labor, laboring in a, like a whirlpool or a tub, that she's in labor. That's the other thing they have in Valley Hospital, they have, like a tub. I've yet to see anybody use it, but they say they are using it, you know. It'd be interesting to see somebody laboring in a pit, you know, like it's not a bathtub, it's like a jacuzzi kind of thing. And they put it in place, I guess, last summer, and they said, you know, they probably have one person a week using it. But and if you go to the point, you'll see there is a video that has a woman laboring in a whirlpool. Okay. Okay, so here we have a picture of little baby feet. Okay. Okay, so the birth, you know, depending on the woman and her spouse or her loved one, whoever, she could choose between a traditional hospital maternity unit, a hospital-based birth center, so that might be a center out, you know, maybe on the block of the hospital, a freestanding center with midwives, or a home birth. Okay, so it's really a woman can make all these different choices of where she would like to labor. Okay. I'm seeing some pictures of home births, but it's sort of funny because a lot of times you see they have all their kids around watching the mother labor. I'm like, oh my God, talk about traumatic stress there, you know. But like, I don't know. I guess they get over it. It's a good way to have birth control. Let's watch this, kids. Don't ever get pregnant.
Aww.
So
I wish the Kegler was here to laugh.
Hospital or to office, clinic, or whatever. You want to do an assessment on the telephone just to see, you know, a lot of times people think they're in labor, they don't know they're in labor, there's like all this like stress about it. And you know, although I'm teaching this, I've been teaching it and doing this for years. I remember when I had my first baby, like, is this really labor? How come I'm feeling it right in my tummy? It was supposed to go around the back of your tummy. I kept thinking, and my water ruptured. Okay. But the funny thing about that is a girl that I worked with, who also was doing maternity nursing, she was pregnant. She was so funny. She thought her water broke, right? And it turned out it was urine. So I heard about that because she went into the hospital. Our husband's a resident. Her husband was an ER resident. Mine was an ER resident at the time. And we're both working in the school of nursing in Pennsylvania someplace. And so when she told me, oh, I thought my water broke, and she goes in and says, it's just urine. I was like, oh, I don't want to be embarrassed like that. So there's something called nitrazine paper. I'll see what's on this slide here. Nitrazine paper, which they use in the, you know, the triage room to see if you are, if that water you could broke, is it urine or is it amniotic fluid? And it's a yellow, like a tape of paper, and they will dip it in the fluid. And if it turns blue, because the amniotic fluid is alkaline, then it means it's amniotic fluid. Okay, if it stays yellow, it's urine. that's coming out. So I went to the hospital and stole one of those. Like stealing, I was like, with nursing students and everything. I went in, I got the nitrogen paper to make sure I don't come in and make sure I didn't make the same mistake. So when the water ruptured, I went, dipped it in, turned blue. I'm like, okay, all right. But anyway, so you get on the phone, you talk to the person you want to know, their estimated date of birth to determine if it's term or preterm. Okay, so she will tell you her due date. Okay, and then the nurse will have one of those wheels to see what today's date is and how far along she is. Usually, by that time, usually the women can tell you, when how far along they are. The problem is, lay people will say how many months they are. Like I'm 3 months pregnant or I'm 4 months pregnant, and for the person in the medical field, the nursing field, we're always saying how many weeks. So it's sort of 4 months pregnant. What is that? So anyway, fetal movement as to frequency in the last few days. She's still feeling the baby move. Any of the signs of labor that we talked about? Does she have lightning occur when baby drop? Did she have a bloody show? Did she, start cleaning the house like a crazy woman or something? We want to know how many times she's given birth. How many times she's been pregnant. Any previous childbirth experience that she had. She had a quick labor. You want her in pretty fast. She had a quick labor for the first time or second time. You want her in if she's grabbed an 8, carry 7. She's had 7 kids, pregnant for the 8th time. That usually is a quick labor. Okay, so those kinds of things you're aware of. Time frame in previous labors, as I said, was it real quick? Was it long? Characteristics of the contractions: are they coming at a regular interval? Appearance of any vaginal bloody show present? Membrane status, whether ruptured or intact. Okay, and presence of support adult in the household, or is she alone? Okay, so those are important things to know. Components of admission assessment. So now we get her into the hospital. We usually what happens. I used to work with perinatal doctors, meaning high-risk pregnancies, my background, and I worked in their office. And we always make sure that the woman's file or chart was brought over at least a month in advance to the hospital, so she went to labor. The file or the chart was there. If she goes in earlier than anticipated, of course she's vaccinated. Okay. And a lot of times nowadays everything's computerized and show you stuff. So any history to be aware of, physical exam, fetal assessment is again listening to the fetal heart. Okay. Lab work, has she had all this lab work done recently, or usually the CBC, the blood type, and the RH factor are done in the first trimester of pregnancy. Urinary analysis, again, they can get that from her chart. Her Group B stress status, okay. Again, a lot of women are positive for Group B strep. It's something in the flora, in the vaginal flora, that is common. But if she does come back with Group B stress positive, they want to give her antibiotics when she goes into labor. And then the HIV status. Okay. So also you want to assess her psychological status, her cultural background, just in case there's something that we need to know. Okay. The process of labor. Now, what I say to the students is in the labs that we have, right? The first lab and the second lab will be this week. The stuff you learned there in the labs is something that is going to be on your final. The stuff in the first 2 labs are very important to know because you'll have it on your first test, and then you'll also have it on your final. So this is part of what you have in your first lab that people in Carol Jasko's group. Okay. So and this is also a question on your quiz for next week. All right. Labor, the first stage of labor. Okay. And this is from the time the person dilates. She starts dilating and effacing. The end of the first stage of labor is when she is completely dilated, 10 centimeters dilated, 100% effaced. Okay? So that is the first stage of labor. Okay? So in this stage, the first stage of labor, okay, so this is from the time she starts to have real labor to the time that she's ready to push, this first stage. The initial phase of the labor is referred to as the latent phase, okay? So the latent phase of labor is when the where the woman, initially gets into true labor and goes to 3 centimeters, okay? Her cervix goes to 3 centimeters. So when she comes in, she says, I'm 2 centimeters dilated. That means that she is in the latent phase of labor, okay? So 1 to 3 centimeters is latent phase, okay? And then we get into the active phase, okay? The active phase is when the woman is from 4 centimeters to 7 centimeters, okay, dilated, okay? So we have active phase. You see how nicely thinned out the cervix looks here. There's the latent phase here. So 4 to 7 is how many centimeters she is, okay, and that's active. Okay, and then you have the third stage of labor,
Oh, it was in the wrong
last
one.
phase. The third phase of labor is referred to as the transition. Okay, so she goes from latent to active to transition. Okay, transition is 8 to 10 centimeters. So the way the students usually remember it, and I don't know why, but they do, I just say LAT. Okay, that's how the first stage of labor has LAT in it. Okay, meaning latent, active, and transition. There you go, LAT. Okay, from there you get to when she's 10 centimeters dilated in 100% E phase, when she's in transition. Once she gets to that point, totally, dilated and thinned out, she goes into the second stage of labor. Okay, the second stage of labor here is when the woman is pushing. Okay, she's pushing the baby. You can see the head starts to crown, meaning you can see a little bit at the top of the baby's head. Okay, when the woman pushes. So this is, again, she starts to push when she's completely dilated and 100% effaced. Second stage of labor is from pushing of the baby, from 10 centimeters, pushing the baby, and the baby is born. So the baby is born in the second stage of labor. Okay? Birth of the baby. The third stage of labor is from the delivery of the baby to the delivery of the placenta. Okay? And you can see here, it's the third stage. The baby came out, okay, the baby's head's crowning, the baby comes out, and then this is the cord, they cut the baby's cord, okay, and the third stage, the placenta starts to come out. And how do you know that the placenta has moved away from the wall of the uterus here? Is that this cord, the baby's umbilical cord, will start to come out further and further, okay? And also sometimes the uterus itself gets a little bit like rounder, so you'll see like a global kind of roundness to the belly, and there might be a gush of blood coming out at the same time, and then you know that the placenta will come out. Okay, so the third stage is from the birth of the baby to the birth of the placenta. Fourth stage is recovery. Okay, recovery is the first 4 hours after she delivers. Okay, this is when you're going to assess her vital signs, you're going to check her lochia, her fundus, and all that to make sure she's not hemorrhaging. So those are the stages and phases of labor. Okay. And then here is, again, if I could get online, I'd show you. I'm going to find out what my password is and get online. You see all this here before labor begins, showing the cervix, the birth canal, the uterus is up here, pubic is there, and then early labor. Cervix dilated, and this doesn't go all the way. Baby's head is crowning here. And you start, every time she has a contraction, you might see a little bit of the baby's head. Okay? Off the baby's head. The head is emerging. So there's a hand on the head. Okay, and then the baby is born. Okay. Okay, we just talked about that. The first stage of labor has the 3 components, LAT. Okay. And again, there's different positions women can take. Usually they're on their cell phone, not on the text line, okay? You see that a lot of times, she has her monitor still on her, but she's standing up. They try to, what they try to do with Valley is they try to get the patient to move and stand up instead of laying in bed. Laying in bed is not, it has to work on gravity. If you're laying in bed, it's gonna be a longer labor usually. So they want the woman to move around, even squat down, sit on the ball, whatever. So they really want the woman to move. Okay, so you see here, so we've got over, what is this, a kiddie pool? Is that a rubber ducky? Whatever works, right? I'd love to see, I really would love to see a whirlpool or jacuzzi delivery. Because I want to see where the nurses are. I want to see how the doctors are. I want to know, do they have to go in there with her?
I think they just swap by.
That's what I'm thinking too. Because I'm thinking that water is probably messy. With the blood of the bomb and the amniotic fluid, maybe poop, urine, you name it, in that water. I wouldn't want to drink that water. Yeah. Turn it off.
Just slap it off. Oh. Oh, we get it. Oh. Shh, Gabby, stop talking. Why did you talk to yourself? Yo, it's not. It doesn't go with the slides. It's pissing me off. Huh? It doesn't go with the slides. He's pissing me off. Are we done? No, she's going somewhere. She's opening something else. See? Told you. No.
Continue. Continue with the X.
Just do.
Yeah.
It's not every time I go to a porno. It's not every time I go to a porno. It's not every time I go to a porno. Never mind. You're an idiot. I said it's not. I was like, it's not every time. It's not like. That's not every time I go to a porno. What's that to do with it? It's continuous. It's the site's not recommended. Oh, we're talking about. Oh, what happened? What happened?
Why do you say that?
No, because what was on the screen? I just said continue. It said continue. Oh, what are you talking about?
We talk about
The gym?
I was like, once I'm mad,
I'm not. I know mad people there. I know everyone there.
it is all over Burger Food.
Huh?
It is like all over Burger
I know. Every time I work out, I usually talk to everybody. Huh? I mean, you are. I mean, like, I got nothing else to work out with. So why would I pay for retro? Huh? My friend Jerwin, the guy I work with. I listed him because he just started and like I look, it makes me feel, yeah. Like I could, like the other day I was like he's like, yo, how much do you curl for biceps? I was like he's like, oh, the most I've done is like 40 on dumbbell. And he's like, yeah. Like, oh. What, 40 pound dumbbell? Curl 40 pound dumbbell?
I want a hot chocolate.
Huh?
Give me a hot chocolate. You owe me $5.
No, I don't. What?
Dude, Taco Bell last year, you never paid me.
Nigga, I shit that out already. Don't count.
Where's my bottle?
Where's my bottle?
It's at home. I showed you a picture.
I'll take you to the liquor store. I'll get you one.
You said you're gonna get me that new Patron.
You want the cafe?
Yeah.
I asked you and you.
I said yeah.
Oh, you said yeah.
Or my arms.
I got you. You like that? You like it? The cafe.
That's probably why.
It's like Bailey's. It's like Bailey's, yo.
What are we doing? What's going on? I know.
Kid in a liquor store.
Look at this.
It's supposed to be below.
I find it.
No.
Jax.
I'm not looking. Got him. But not really.
Look. Yeah. No, yeah, I feel like this. Eric Shower sent you a Snapchat. Oh, it's always something special, Eric. It is always something special.
Eric, your Snapchat though.
Send a Snapchat to Keith.
Can I leave you
But
a
it's
note
you.
on your notes?
He's gonna be so pissed. He's like,
Yo,
this is what you
I'll
do.
leave you a note, alright?
It's like, why is he on
note.
your phone?
No, let's take a
Send a
snap.
Snapchat to
No, yo.
Let's send one to him.
I'm gonna leave you a note. You can't look.
Are you looking at my pictures?
No?
What the hell, Jax?
There's notes. Oh, it's right here. Book.
Yeah, no. You're writing a note.
How do you do it? How do you write a note? How do you write a note, yo? Yo, what's your passcode?
Your business.
Yo, come on, just tell me.
Hey, no.
I was trying to change your passcode.
It is.
That's why I didn't know you had to enter it first. That's why I was like, how do you write a note?
Maybe you didn't send it to me.
Yo, I didn't get no Snapchat from Eric.
What?
Why does it log me out of this Wi-Fi shit all the time? Yo, what are we doing? Are we on another break?
I'm not creative right now. I'm not creative right now.
Ken, mine's not connected. Look,
Sorry.
it's okay.
This is all I'm gonna do.
What?
When I'm at home, I send random Snapchats.
Go to Google.
I wonder how much data
Google.
I'm fucking using.
Fuck Snapchat.
That's not better for you.
Makes no sense.
I haven't gotten it yet.
Look at your face. He never has it. You like it?
I'm not pissed. I'm not mad pissed. It's working.
I'm trying to be creative. I can't be creative. The idea has to come to me.
Come close to me. Damn, Eric.
What?
I don't like yellow.
I've been getting. That's like my fifth one.
There's like a freshman
Holy. Tap to load. Wow, I had to tap it to load it. That's what she stated. What? Oh.
Oh my god.
Oh, she.
Felt like you were gonna just throw it back Or not knowing you.
What?
No.
No. Come on.
Wait, you can look at it?
No.
Quick.
No. You gotta look at mine first. Yo, you guys are gonna die. You guys are gonna die.
Wow.
Look at mine. Look at mine. No, you gotta screenshot. Screenshot.
Just to keep your finger on it at the same time.
You saw the one?
Yeah, I saw yours.
You just screenshot?
Wait, did you get it?
I sent it to you.
So
I sent it to Dad.
I think I just got the screenshot.
Oh my god.
You didn't see it? Look, what is that? I can't breathe. My mouth is relaxing so hard.
Maybe.
I told you can't be fun.
Show that Waylon said to use something Neo-Gel, Neangel,
Oh.
What's it
I
called?
don't
I can't
remember.
breathe.
Real sport.
But
I know you know what I'm capturing that. What? That you know what I'm capturing that. What we always say when we're cooking. What we always say when we're cooking.
wait, what?
Like in the weekend.
What? That's a picture. What? That's that.
Did you guys do anything? I did. And then I know by those in assessment.
It's too slow.
I got that shit so good, right?
All right, we'll go back to this one.
I got
you
it
capture
so
that moment?
I got it so, huh?
You capture that moment so good.
Was it all up in the face?
Oh, we're still going? Damn.
Yeah, we're going.
Yeah, I know, you know what, because it's not, too slow. I'm gonna try to, get here earlier next week, to try to figure it out, so you can see.
Oh.
I want Dunkin' Donuts.
Would you like some hot chocolate?
I want dark hot chocolate.
So gross.
With whipped cream.
Alright, so doing assessment, listening assessment.
Oh, there it
And
is.
This is from the chapters 13 and 14. So, just realize this should be, you should read this, fill in some of the materials to understand it. But, I just put the PowerPoint stuff that is, the book company gave me to you guys, okay? So, we continued assessment, women's knowledge, experience, and expectations for vital signs, vaginal exam to see if her membranes are intact or she ruptured them. If she's dilated, it's based on what stage the baby's at. Frequency, intensity, and duration of her contraction, her pain level, her coping ability, and the fetal heart rate, which we used in the Leopold's maneuver, and her amniotic fluid. When you're looking at the amniotic fluid, I always say to do what they call TACO. TACO. What time did the membranes break? Okay, or when did her bag of water break? Okay. What amount of fluid was there? Again, if you're in the field, you know what's too much or too little. Color. Okay. Okay. Now you want it to be pretty clear in color. It might have some of the baby's hair or from the baby's body in it, or maybe some white cheesy kind of stuff that's on the baby's body. It should be clear. And somebody said an earthy smell. I don't know what that is. Smell the ground, so it's time. What time do they break? The amount of fluid, the color, and the odor. Okay. The color again should be clear. If it's green color, it's something called meconium, which the baby pooped in utero. Okay, so that's important to know. If it is red, she could be bleeding, something wrong with her placenta. Okay. And if it's yellow, the baby could be jaundiced, like really yellow. Okay. So those are the things. And the odor, earthy odor, shouldn't be foul smelling from the infection. So those are the things you look for when the woman does rupture her membranes. Okay. And then we talked about the Leopold maneuvers. Okay. We did that already. That and that. Okay. And then other assessment, again, analysis of the amniotic fluid. The way they can make sure paper is called nitrazine paper. That blue, that paper will turn blue. Okay, turns blue. The amniotic fluid is alkaline, so that means it is amniotic fluid. So that's nitrazine paper. Another thing they could tell if it's amniotic fluid is they'll take a little bit of fluid and put it on a slide and let it dry, and then they take that slide and put it under a microscope. They look at the fluid that has dried, and if it looks like a fern-like pattern, like a plant, like a fern plant, that means it's amniotic fluid. Okay, if it dries and looks like a fern plant. Okay. Fetal heart monitoring, they can either handheld monitor or electronic monitoring. Intermittent versus continuous monitoring. If the woman wants to walk around a little bit, she would have the intermittent monitoring of the fetal heart. Continuous, they have the belts around the woman, okay, and she really sort of tied to the bed at that point. External versus internal monitoring. Usually you'll see external for the most part, unless there's a problem picking up contractions or the heartbeat things go internally. Fetal heart rate pattern, you want to get the baseline of the baby's heart rate. And then again, this people in the lab, we'll see table 14.1 in the chapter.
Taco.
My lab group hasn't gotten this handout yet. Okay. So again, you're looking at the analysis of the fetal heart.
That's not it.
What you're looking to evaluate is the status of the oxygenation of the baby. So remember I said at the peak of the contraction, what happens at the peak? The baby doesn't get a lot of oxygen. There's no oxygen at the peak of the contraction. If it's a healthy baby, they're fine. If the baby has issues, like it's not getting enough oxygen all along, then you might see an unusual pattern in the fetal heart rate. Okay. The fetal heart can be taken as an intermittently with a Doppler device that they, if women walk around walls, they say you want your back every half hour so we can monitor your fetal heart. They have a little device they can use to hear it. Okay. Or the device can be the electronic monitor where they're strapped down. And what I said already, they're allowed to walk around. Guidelines for fetal heart, and again, this is from the second edition, page 368. I don't have the number for the third edition. Okay, so guidelines for fetal heart. Initially, you want to put the woman on the monitor. So they want to put this is to monitor her uterine contractions. So what they're doing here is they take this monitor, it's called a TOPO monitor, and they try to find where the fundus is, which usually isn't that hard, around the fundus area above the belly up button, and they'll pick up on this monitor her contractions. The other one here, again, you can tell that this baby is going to be vertex because this is where, one where they're trying to get the baby's heart rate, and it looks like it's below the mom's belly button, so the baby's going to come out head first. Okay, so this second belt is for picking up the heart rate of the baby. So they keep her on for 10 to 20 minutes when she first comes in for labor and delivery, just to see, get a baseline, what's the real heart rate. It should be anywhere from 120 to 160, okay? And then they'll do it every half hour or so, depending on, what she's doing in labor, as far as is she active, is she latent, or is she in transition. Every 15 minutes, if the woman's in active labor, if she's high risk, meaning she has high blood pressure, or she has a bleeding problem, she has diabetes, so they'll do it a little bit more frequently if the woman has some kind of risk factor. During the second stage of labor, that's when she's pushing, okay? They will do it every 15 minutes for a low-risk patient, meaning she has no health problems, and they'll do it more frequently every 5 minutes for a person who is who's had some kind of medical problem going on. Okay, and as I said before, external contraction monitoring, the tocodynamic or TOCO senses the pressure of the fundus. Okay, so the fundus is top of the uterus, and you can see here. This is a monitor, sort of looking like a monitor at the bedside. It's hooked up, and it will gauge how much pressure it feels for contractions. And it will pick up the baby's heart rate, and it comes out in a graph form here, and you can see it, the way it's working. The pressure changes are converted to a pattern, and it's a tracing. Okay, there's some limitations. It's not 100% correct, but it's pretty darn close. Okay. Internal fetal monitoring here, okay? This is when you're not able to pick up the woman's contractions or the baby's heart rate for some reason. And so what we'll do is electronic scalp electrode, and then we have the internal fetal heart monitor on the baby's head. Okay. And then there's, they can also do an interpressure catheter for the contractions if they're not able to pick up the contractions very well. And they would put that onto the uterus. So to be able to do the internal monitoring, what you want to make sure is there's criteria that has to be met. The membranes have to be ruptured, because if they're going to go in here, they have to be able to put the monitors inside. So if the baby's still in a bag of water, it makes it very hard to do that. She has to be dilated at least 2 centimeters so they can actually get in there to put the monitors in. The concentric part low enough to allow placement of the scalp electrode, so the baby's head should be at least at the ischial spines. And it has to be somebody skilled who's done this before. Okay? This is what it looks like, the internal monitor. Okay? This is for the baby, and this is for the mom. And what they end up doing is just this plastic thing comes off
Which one's new?
once they're able to reach
Is
the
that third
baby's head.
edition?
So that's what actually part of it.
The new one's second edition.
She keeps saying this is from the second one. This is from, where's this from?
See how the baby's
I think it's
plastic
from the
is
second
coupled
edition.
in there.
So what the fuck is it all?
And then interior monitoring provides, more accurate assessment of frequency and duration of contractions. Okay. This is what I was talking about before, a graft that we would be looking at, okay? So here is the contraction, okay? Each one of these little lines here are 10 seconds each, all right? The dark line here, the dark line there is 1 minute. Okay, that's 1 minute, right here, from here, the dark line to the dark line, each one in between is 10 seconds. So here you can see they're timing the contraction, okay? You have, this is the beginning of the contraction here when it starts to slope up, okay? And to time the frequency, you go from this contraction here to the beginning of this contraction. So what you can do is with this one, it's nice because it starts at that line here. Okay, so you go 1 minute here, 2 minutes there, 3 minutes there. The dark lines are minute. That one to that one's a minute, that one to that one's a minute. So the frequency of the contraction from this one, the start of this one to the start of that one is 3 minutes. Okay? The duration here is the beginning of the contraction to the end of the same contraction, and they count by 10 seconds each. They count it to be 60 seconds or a minute. Okay. And then here, the millimeters of mercury, the intensity, this is probably a moderate contraction, which is 50. Okay. The heart rate is up here, okay, of the baby. You never want to see a straight line because that means the baby, it might be brain damaged. You want to see this fluctuation of the baby's heart rate. You don't ever want to see a straight line. You want to see nice movement, up and down movement. That's referred to as variability. We're looking at the line and seeing that the baby has good variability because it's not a straight line. It's just going up and down, up and down, up and down. When you see something that's straight, either the baby's not getting enough oxygen, or the baby might be, brain injury somehow or another, not getting enough oxygen. So you want to see this up and down variability. You can see here the numbers. This is the baby's heart rate. So the baby should be between 120 and 160 up there, and this baby is within that range. Okay, so that's good. Again, we talked about the baseline is really when you want to get a baseline of the baby's heart rate. The best time to do it is in between contractions. The baby's not stressed in between the contractions. And when the contraction, the little hills are there, you don't want to get the mom's vital signs, you don't want to get the baby's because it's not going to give you true value. So to get the baseline of the baby, you want to make, this is when she's not contracting the mom. Okay, so
Contractioning.
there. So the baseline of the baby's heart within that time frame looks like it could be from 140 to about 150. See how we go? This is the lower part here, 140, maybe about 150 there. So baseline, you see to get it when she's not contracting. Okay. Tachycardia, bradycardia, and variability. Tachycardia can mean that there's an infection. The baby might have an infection, maybe from mom's uterus. Maybe her membranes have been ruptured for a while and the baby's now getting an infection. So tachycardia can be from that. Could be if the mom used cocaine, right before she went to labor, because that can happen. Bradycardia in the baby, again, it could be some kind of cardiac problem, or it could be the mother just had some narcotic or medication to slow up the baby's heart. Okay? But when mom takes it, it does go to the baby, so sometimes you'll see that going a little bit slower. Variability is what I talked about already. It has to have that bouncing up and down kind of look to it, the baby's heart rate. A lot of times they'll look at it and they'll say, wow, there's no variability. That's not a good sign. That's either the baby's not getting oxygen or the baby has some kind of brain damage. So you want to make sure that it bounces up and down the baby's heart rate. And there can be accelerations in the heart rate when the baby moves. Okay, so if the baby's kicking and moving, the baby's heart rate goes up. Okay, decelerations, we'll have to talk a little bit about that. Some of them are non-reassuring decelerations in the baby. Okay, and that has just different issues depending on what. Okay, so here we are looking at the different types of fetal heart decelerations. You guys had this at Harold Jasko's class? Remember? No, I don't remember, but we had it. That's right. I was like, we had a meeting last week. Everybody's looking at me. Last week. What did I do this week? Oh my God. Yeah, so I forget. All right, so here we go. Fetal heart decelerations. Okay. You guys in my lab will get this, this printout. I have it for you for the handouts in the lab this week. So we have early decelerations, right? And what you see with the early decelerations is the baby's heart rate is a mirror image of the contraction. Okay? So as the contraction goes up, the baby's heart rate goes down. Right? And then when it peaks, the baby goes to the lowest level. When the contraction's over, it gets back to baseline. See how that works? Contraction is a mirror image of each other. Early is good. Now, I don't know, did she tell you that? Coming to dinner for early is good. Which is not in my house, though. I don't want you to come to my house early because I'm never ready till the last second. But let's say early to class is good. You're here, you're ready to go. So that's a good, when a baby has an early deceleration, it's good. It's okay. All right? late deceleration is not good. So if you come late to class, you're no good. So just remember, early is good, late is bad. Okay? And variable can also possibly be good or bad. So this one is good. So we just watch the baby, watch the monitor. The late deceleration, how it looks. The head compression. Sorry, I have to bring that up. Head compression is usually why the baby gets these early decelerations. Usually you see it when the baby's pushing. Okay, so the head's sort of, being pushed also. So that's from the head compressions. Then we're going to go here. This is the late deceleration. And I said it's no good, too late. It's no good for the baby either, because the late deceleration is from uteral placental insufficiency. So what does that mean? It means the uterus feeds the placenta, right, with blood and oxygen, right? Comes from mom, it goes to the placenta, it goes to the baby by the umbilical cord. So what happens with that is, if by chance something's going on in the uterus that's not allowing the blood to flow into the placenta, it will cause this late deceleration. So what are some of the things that cause late deceleration? High blood pressure, right? Because it constricts the arteries, so that means the blood's not getting to the baby as well. Low blood pressure, because what happens is there's not enough pressure to get the blood to the baby, the oxygen to the baby. Cocaine can constrict the blood vessels and cause the baby not to get enough oxygen and nourishment from the mother. So those are some of the examples. Whatever is going to stop the blood flowing to the placenta to get to the baby is a uteral placenta insufficiency. Okay, so that's a late deceleration. And what happens with that is, how they define it is that it starts late in the contraction. So remember I said when you have a peak of the contraction, what happens to the baby? It doesn't get any oxygen, right? At the peak of the contraction, the baby gets no oxygen. If it's a healthy baby, it's okay. If it's not, it might have a late deceleration. So peak of the contraction, when the baby has no oxygen, the heart rate starts to go down, okay? Right there. And then it goes, once the contraction's over, it slowly gets back to the baseline. It's very subtle. And you can see, if you look at this strip, you can see there's no variability. See how it's like bouncing up and down here? It's sort of flat looking also. So there's no variability as far as beat to beat and the heartbeat. And if this goes down and there's not any oxygen, the baby's not doing well with it. So what do you do? Does anybody remember from Carol Jasko's class what you do? Well, what you really want to do is try to see why this is happening. So you get the vital signs of the mom. Is she high blood pressure or low blood pressure? That can be a problem either way. If she's lying flat on her back, is that good?
No.
No.
She shouldn't be flat on her back because her vena cava and the uterus, so the uterus is heavy and big with the baby, that squishes the vena cava and can cause the woman's blood pressure to go up or down. Okay? So she should be on her side. They always say the left side is best. Okay, so it gets the baby off the vena cava. So if she's on her back, it's causing maybe the vena cava to give less blood to the baby now. Okay, because she's lying, the baby's lying right on the mom's vena cava. So what you want to do is she's on her back, have her go on her left side. Okay. You usually will give the mom oxygen because what this is showing is the baby's not getting enough oxygen, right? So you give the mother oxygen so that it gets to the baby, okay? The other thing you can do, if she's on something called Pitocin, Pitocin makes the woman contract, okay? It helps the woman contract in labor, you know? Sometimes, if you see the fetal monitoring and the baby is having this late deceleration, it could be because the contractions are coming too close together, you know? Because what did I say, the peak of the contraction, what happens to the baby? It's not getting oxygen. So if she's on Pitocin and her contractions are coming every minute to a minute and a half, the baby doesn't have any time in between to get oxygen. So the nurse is allowed to turn off the Pitocin. Everybody hear that? That's a test question. Okay? You are, as a nurse, allowed to do that. Okay, so we do all that, and the baby's still showing, the heartbeat's still showing these kind of late decelerations. Okay? So what happens then? We Usually if we see this going on, we will ring the bell and the doctor will come in and say, we have to do a stat C-section, okay? And the reason for that is because there's no variability, and this is showing also showing signs that the baby's not getting oxygenated well. Is not able to take the contractions. Yeah.
I have a question. Can you tell like the intensity of what the next contraction is going to be like, or do you only see it as it is occurring?
But actually, you can see it on the monitor before the woman starts to feel it. So all of a sudden, you see the monitor start to it's like a flat line. All of a sudden, you see the monitor start to go up. I'm like, oh, you're starting contractions. Oh, I don't feel it yet. She does it after a few seconds. So you can't really tell. Yeah.
So you're basing your assessment on the contractions and on
Yes. Yeah. On the contractions and the baby's heart rate. Okay. Anyway, so then that could be an emergency C-section right now because something's going on and the baby's not getting oxygen. The last one, and then we'll finish after this. Okay. The last one is variable deceleration. Okay. Variable is usually from umbilical cord compression. The baby is lying on its own cord, or the baby might have nuchal cord being around the baby's neck. Okay, so variable decelerations mean that it varies. It doesn't have to be with a contraction. It can be a contraction. It's just the baby is lying on its cord, on its own cord. So what they can do with that is change the mother's position. They can, if the baby's lying on the cord, sometimes they'll change the mother from one side to the other to get the baby off the cord. Sometimes they'll have a human being on her hands and knees to get the baby off of the cord, or they'll do Trendelenburg position where her head is down, her feet are up, again to try to get the baby off of the cord. Okay. The other thing they can do is an amnio infusion. What they'll do is they will take a IV bag, okay, and they will warm it up, and then they will put the IV tubing into her uterus and open up the tubing, the little thing, clamp. So you open that up, and that will bring fluid into the uterus to make the baby float and get off the cord. Okay, those are some of the things they can do to get the baby off the cord. Okay. How do you know it's a variable deceleration? Look at how distinct it is. I always say it's either you have little like V's, looks like a V, or a U, or a W, okay? And which they call the shoulders, like it comes down, goes back up, and so it goes high, and gets back on the baseline. So U, V, or W are variable decelerations. If the baby's heart rate goes down to 60 and stays there for a minute, that's a stat C-section, okay? The baby has to get out. So with these two last ones, variable and late, there's that possibility they have to get the baby out quickly and have a C-section, okay? Any questions? You made it, everybody? I know, it's a long day. You have some other nutrition or something, right?
Is being prepared for the C-section?
Not yet. I'm doing them
Prior
tomorrow.
to this?
Oh, yeah. It's really,
Did you finish
it's really,
them?
we've seen it a few times at Valley
Oh, you're
where,
not gonna be here tomorrow.
they really build
Ching, getting paid over here. Ching, getting paid over here. Thursday.
Oh, like it's like
And the first thing they do is they come in with the consent forms, they get the woman on the
Stop
gurney,
recording.